Good afternoon and welcome to the PRI Frier Levitt webinar on legal issues and guidelines associated with reopening practices post-COVID-19. This webinar will address clinical and legal considerations for medical practices and healthcare providers in the state of New York, reopening their offices and adapting to some of the new requirements that are being imposed both at a state and federal level for these types of practices. We have a good team here today. We're all coming from the law firm Frier Levitt. Frier Levitt is a national boutique healthcare law firm. Our main office is in Pine Brook, New Jersey, but we have an office in Uniondale, New York, as well as an office in the financial district in New York City. We focus exclusively on representing the healthcare and life sciences industries. Our clients include doctors, hospitals, surgery centers, labs, pharmacies, drug companies, and wholesale distributors, as well as pretty much any ancillaries in between. As I mentioned, we have a good team here today. We are all lawyers, so it's important that we specify this disclaimer that everything put forth in this webinar is for informational purposes only and doesn't constitute any type of legal advice. We would encourage you to seek legal advice if you have specific questions, and we'll provide contact information to get in touch with us at the end of this presentation. About the presenters, I'm joined by my partner, John Morrone. John Morrone is the chair of the Life Science Regulatory Group. He's also the managing partner at the New York City office. He, in addition to being a lawyer, he has a background as a clinician, both as a registered nurse and critical care paramedic, and also has a career in healthcare, having worked as a hospital executive for some time. Myself, Jesse Dressler, I'm an attorney in the firm's Life Sciences Group. I am partner heading up the pharmacy practice group in particular, but one area that I've been particularly involved in recently is the rules around reopening as a result of COVID-19. And so I'm going to talk about some of those issues today. I'm also joined by one of my colleagues, Dr. Larry Kobak. Larry, in addition to being an attorney, is also a podiatrist and has spent a career practicing as a podiatrist for quite some time. He is going to be talking a little bit about some of the considerations for practices as they begin to open up, primarily from a clinical perspective. And finally, we're joined by Associate Christopher Caltavuturo. He is an associate in our firm's litigation department. He's going to be talking a little bit about the PrEP Act and some of the implications that it has for providers, both in terms of ways that it provides protection, but also in terms of opportunities that it provides. So with that, we'll hop right into the presentation. And I know one of the things that is first and foremost in a lot of folks' minds is we continue to watch the cases go down in this region like it's the stock market. We are all kind of focused on when is it going to get back to some semblance of normalcy? When are we going to get back to being able to let people back into offices, being able to let patients come back in, being able to begin resuming elective procedures? These are all questions that we face on a regular basis. And kind of the flip side of that coin is, what are the implications of all of that? What are the concerns that I should be aware of as I start letting employees come back, as I start bringing patients back, and as I start to handle some of these elective procedures? And so what we're going to start by talking about a little bit today is the reopening guidelines and kind of the different sources and what they are. Comment that I'll make at the outset. The number to go through what is ultimately required as a result of some of these reopening guidelines could take, it would be more than an 8-hour webinar. These documents are oftentimes quite long, and there are many of them. So we're not going to be able to get into the specifics of every single piece of guidance, but instead we're going to focus a little bit more on what are the sources of guidance. What are the things that you need to look to in terms of how you make decisions about reopening and how you actually implement the reopening. So I have on here several key sources that everyone should be following and should be aware of. The first is CDC, Center for Disease CDC guidance. They've put out guidance on a number of issues relative to not just personal care, personal hygiene, how to limit infection and the spread, but also guidance on how employers should begin to develop plans for letting employees come back, how healthcare companies should begin to address issues like personal protective equipment and strategies on how to isolate potentially vulnerable employees or employees that might have been exposed. We also have OSHA. They're putting out requirements under the auspices of the Department of Labor relative to things like workplace safety. And these are particularly important in the context of healthcare, particularly where staff or practitioners may be exposed to, at the very least, the general public, if not people that are actually known to be infected with COVID. There's also the guidance that's coming from the New York Governor's Office, primarily the New York Forward Reopening Plan. In addition, there's guidance coming out of the New York Department of Health, and then finally there's CMS guidance. And I'll get into a little bit about some of these different forms of guidance that are out there, and kind of what the big picture items of what you need to be aware of. So I'll start actually with a discussion about New York's governor and kind of what's going on there in terms of reopening, because this is probably the most topical. So New York Governor Andrew Cuomo created the New York Forward Reopening Plan. And this is a multi-phased approach to begin resuming operations within the state on a couple of different fronts. The first phase dealt with things like manufacturing, construction, curbside retail, some limited types of operation. The second phase dealt more with in-office work and some forms of limited outdoor dining and things like that. The way it had been designed by the governor's office was to be rolled out in different regions. So for example, New York City region was on a different timeline than other regions within the state. As of this coming Monday, New York City will be the last of the regions to enter phase 2. Phase 2 begins to allow office work to resume. It allows outdoor dining to resume. It's the last of the regions to kind of hit that phase, and all those phases are tied to metrics surrounding the decreased number of cases, increased availability of hospital beds, things like that. An area that's of particular concern for physicians and medical practices and healthcare providers is the guidance that's come out on, for example, elective procedures and non-emergent procedures and elective surgeries. So on March 20th, 2020, Governor Cuomo signed the original New York State on Pause executive order. And in addition to closing non-essential businesses statewide, it did create exceptions for essential services like healthcare, and suggested that sick individuals shouldn't leave their homes unless they were going to receive medical care, and only after a telehealth visit determined that leaving home was in the best interest of health. So, that was the first form of guidance that came from the governor's office, and it created the carve out for medical practices, which as a result has created a little bit of uncertainty for some of these providers as they wade through all of these stay-at-home orders. On March 23rd, Governor Cuomo signed Executive Order 202.10, and that authorized the Commissioner of Health to direct all hospitals, surgery centers, office-based surgery practice, D&T centers, in order to increase the number of beds available to patients by canceling all elective surgeries and procedures. So that essentially canceled all forms of elective surgeries or elective procedures. That continued in place until April, the end of April, on April 29th, when Governor Cuomo signed Executive Order 202.25 that modified the previous executive order and allowed the resumption of certain elective surgeries and procedures so long as certain criteria were continuing to be met in different regions. That includes hospital inpatient capacity requirements, decreases in COVID-19 hospitalizations, etc. By May 13th, 2020, hospital and ambulatory surgery centers were permitted to resume surgery on elective surgeries in a number of counties, but there were still restrictions in others. But then finally, as of June 8th, 2020, New York City, having entered phase 1 of reopening, the governor allowed even those regions to begin doing elective surgeries. Now, the important thing is, even though there are the ability to begin resuming some of these things, it's not a carte blanche. There are several requirements, and I would encourage it, if you're beginning or have begun to do some of these things, that you're following scrupulously some of these requirements. Along the same lines, the New York Department of Health has put out guidance on how it expects businesses to take care of employees as they come back in and as they return to work. And one of the hallmarks of what they have required employers to do is what's called a business safety plan. If you haven't seen it and you haven't downloaded it, you haven't completed it, you have to. All employers in New York are required to complete this. And it talks about things around the scope of maintaining social distancing, adherence to cleaning procedures, adherence to screening procedures for employees and for guests. It's an important thing that all New York-based employers have to complete if they're going to have any form of on-site operations. Kind of along the same lines with elective surgery, CMS had also come out with directives that as of March 18, 2020, all elective surgeries, non-essential medical, surgical, and dental procedures should be delayed during the 2019 novel coronavirus outbreak. That continued until April 19th, where they allowed states that had met certain gating criteria set forth by the White House to begin the process of phasing back in some of these elective procedures. And again, on June 8th, they further expanded the ability to resume elective procedures. So from that perspective, many of the restrictions that had barred altogether some of these things have kind of been lifted. But again, it's not without strings attached in certain conditions. And kind of along those lines of conditions, the other things that employers need to be aware of is what are their requirements as it relates to not only bringing folks on site, but also accepting patients on site. You know, what are some of the things that they need to follow? OSHA sets forth several guidances and recommendations using a combination of standard precautions, contact precautions, airborne precautions, eye protection to protect healthcare workers from exposure. Employers of healthcare workers are responsible for following several OSHA requirements, including OSHA's bloodborne pathogen requirements, PPE requirements, and respiratory protection requirements. Those are all set forth in the Code of Federal Register. OSHA also sets standards regarding engineering controls, administrative controls, safe work practices, and PPE. So the level of requirements that have to be followed in order to create a safe work environment for medical practices are fairly extensive, but they do vary a little bit with the degree to which there's risk. So for example, if someone is doing an invasive procedure on someone that has known COVID-19 diagnosis, that is a very high risk and obviously requires much higher attention to compliance versus someone who might be doing a purely administrative function, not seeing patients, not even seeing really many other employees. That's very low. And so there's a sliding scale in different levels of risk, and as a result, different levels of things that have to be adhered to. In terms of some of the CDC guidance, a lot of this focuses on the protocols that have to be done within the office, you know, in terms of cleaning, in terms of screening employees and making sure that they haven't had known exposure and don't have symptoms, and if they do, keeping them home. Same thing goes for patients. Now, obviously, it's a little bit different in the healthcare space, and there are separate guidance that New York State has put out about how to handle some of these things. You know, so for example, if you have a patient that's coming in for, let's say, physical therapy, it makes sense to screen them and make sure that they don't have COVID. If you have someone that is coming in because they're sick and they need to be treated, it's a different standard. So those are things that are set forth in detail in some of these New York guidances from the state of New York, and I encourage any practice that's beginning to resume its operations to really focus on those and make sure that they've developed a pretty sound safety plan and policy and procedure around this. And so with that, I'll turn it over to my colleague, Larry Kobak, who's going to talk a little bit about some of the actual operational and clinical aspects of this and kind of utilizing some of his own experiences as a practitioner.
Thank you very much, Jesse. Thank you. It's a pleasure to be back with PRI. And let's talk about something that's very important to all of us who are in practice. It's extremely important that we do not forget to record in our records, in our patient charts, any kind of patient interaction that you might have had since your office closed, or if you went to a telemedicine model during the office closure. It's not enough to have just spoken to someone on the phone and you're going to remember in your own head what occurred or what didn't occur. It has to be written down in your chart or inputted into your EMR. There's no change as far as the sum and substance of your medical records just because you talked to someone on a phone or had a video interaction with them, such that your records should reflect any changes or additions or subtractions in what you were prescribing for them, any kind of referrals, any kind of interactions you had with your patient's other healthcare providers. That should be put in the record too, because it's supposed to be there. Also, it's important to note when the patient's supposed to come back again to your office or for when the next phone call is going to occur. Your chart should also note any kind of progress or lack of progress during that telemedicine encounter or that the phone encounter. Now, if you're using an EMR system or you're using computers, which I'm sure virtually all of you are at this stage, it's important to remember and change your passwords, all right? You wanna make sure that you're not going to be easily hacked. And again, every person that's inputting information into your EMR system should have their own unique password. One other thing that hopefully you haven't forgotten during your time away from your office is the fact that you are required to access the PMP, also known as iStop, whenever you are prescribing opioids or other controlled substances such as benzodiazepams. All right, this is extremely important. It's not optional, it's the law in New York State. And it's not only that you access it, but that you act upon what you see. So that if you see several practitioners prescribing opioids or benzos or anything of that nature, that should be noted in the corpus, in the body of your medical chart, and you should act accordingly. I don't think you want to be the third practitioner to be prescribing opioids on a particular patient. That could be very problematic. All right, let's move on. The next thing is preparing your room for reopening. Now, Jesse went into a lot of the requirements. Let's dig down a little bit. What are the specific areas that are in your practice that people are touching a lot? Both you will be touching, your staff, and your patients. Well, obviously the treatment tables or chairs, doorknobs, light switches, countertops, handles, desks, certainly phones, computer keyboards, the bathrooms, the toilets, faucets in the sinks, and any kind of touchscreens. These have to be cleaned on a regular basis, not just in the beginning of the day and the end of the day. As Jesse mentioned, you need an actual written plan of attack, which is supposed to be updated from time to time as you realize that a particular type of cleaning and maintenance might be necessary that you didn't realize at first. Something such as a log of how often you are or your staff is cleaning the bathrooms, the sinks, the countertops, the chairs. Are you cleaning the tables, after each patient. That's important. How about how often your staff is changing their masks? And your staff should be wearing masks as well as you. Are your patients wearing masks? Do you have alcohol, hand sanitizer in each of the treatment rooms and in the patient waiting area, in the nurse's lounge if you have one of those? You should have these, at least 70% alcohol, if not soap and water, in all these areas. All right, soap and water is preferred where you have a sink and you have running water. But if not, the alcohol cleanser is fine. Now, here's another thing. You haven't been in your office for a while. You have to have your staff go through all the medications and the samples that you have to make sure that the usefulness date has not expired. This is extremely important. It's an area where a lot of physicians, frankly, get comfortable and forget all about it, such that when, during various reasons why we as attorneys have to go into doctors' offices and be there for Department of Health office inspections, it never fails to surprise me how the doctors have not had themselves or their staff go through their medications and samples in years. So they have samples in their closets that have been expired years ago and have not been dispensed with. That has to be done. Also, you have to go through sterilized instruments and clothing to make sure that they've been sterilized in the appropriate amount of time, such that if you're doing any kind of in-office procedures, usually steam sterilized instruments have to be re-sterilized every 30 days, even though they're sealed in an appropriate retainer. All right? So you have to re-sterilize and date as necessary. That's another thing. You have to check that your gas sterilization, your autoclave are all within working order. Check to make sure that your oxygen is full. Usually you have that little tag on your oxygen tank the last time it was filled. Either you or your staff should take a look, because if you need that oxygen in an emergency situation and it's empty or it hasn't been filled in years, it's too late. It is too late. Check the date on your fire extinguisher, which you should have at least one in your office, if not more than one. Check to make sure, again, that the date on the tag is within the date limit that when you reopened your office. Because again, if there's a fire and you need a fire extinguisher, it's too late if it's not going to work. Here's another thing, and I've had this in my own office when I was in clinical practice many years ago. Check your emergency kit medications. You may be shocked to find that some, if not all, are out of date. Again, when you have an office emergency where you might need injectable Valium or something with a hypertensive crisis or some other kind of emergency, if you need one of the medications in that kit and they're either not there or they're too far out of date, it's too late. You're not going to get a second chance. Not at all. So you have to make sure all the treatment areas are stocked with the appropriate supplies. If we could go to the next slide, I'd appreciate it. Now, we've already mentioned about each room should have an adequate amount of hand sanitizer. They should be easily available for any of the patients. You know, a large part of what's going on, I'm not going to get into talking about having patients, whether they should sign waivers or not, but a large part of what's going on is a perception that you, the healthcare provider, are making sure that your patients feel safe, and that, as important, your staff and fellow physicians and healthcare providers feel safe. That means that the staff is well aware that you are doing everything you possibly can to keep the area maintained and cleaned on a very, very regular basis. That may mean going above and beyond. Rather than supplying the less expensive type masks, you may want to strongly consider giving your staff N95s, because the N95 mask will not only protect the other person, it will protect, at least somewhat, the person wearing that mask. And you're showing your staff that you care about them. That's very important. You're showing your patients that you care about them. That's very important, because if the attitude is such that both the patients, the staff, yourself, you're all caring about each other, and that you are, and you've heard this phrase a million times, that you are all in this together, that's going to create an attitude that's going to pervade your practice setting that will probably be as if not more important than any kind of waiver that you do or don't use or don't use. If we go to the next slide, please. Now, please, while you are out, your CME and licensure requirements have not changed. So while New York State in and of itself doesn't require a certain amount of CMEs every year, unlike some other states, they do require mandated 4 hours for controlled substance / opioid use. You need a course in that. That has to be taken. And if you are getting to the point where you're required, it's mandated for you to take the course again if you haven't taken it already. And that's any healthcare provider, dentist, MD, DO, NP, DPM, DDS, DMD, PA. You all are mandated, if you could write, for controlled substances to take this course. Please don't forget about it. Hospitals, for your hospital privileges, may require certain courses. Your specialty societies may require certain courses. Your own medical group may require certain CMEs. Please don't forget about taking them. They're very, very important. Next slide. Now, this particular slide is extremely important, this particular topic. A large percentage of the people listening to this may not even know what the New York State Physician's Profile is, believe it or not. And this is mandated by the New York State Department of Health as well as the Department of Education. And it's been around for quite a few years at this stage. You are mandated by law to make sure that your New York State Physician Profile is up to date and accurate. And at least during the last several years, the Office of Professional Medical Conduct has been going after physicians and disciplining them if they are not updated on a timely basis. So you have to make sure your profile is updated within 30 days of when your registration is renewed, or within 30 days of when something important happens in your practice, such as you've changed your hospital privileges. Something of that nature. You've changed where you practice, your address. When something important changes in your professional practice or life, you have to change that in your New York State Physician's Profile. It's very easy to do. You can change it online. You can even use a fax machine or on phone. Just type in as a search term on the internet, New York State Physician's Profile, and you will see that they will actually walk you through how you could change and update your profile. If your profile is not up to date, that's not good, because frankly, you can, and it has happened, get disciplined for that. And it's just something that's so easy that either you or your staff could do that there's really no excuse for that at this stage. Next, please. We're going to be talking about your malpractice insurance. Now, there are fine companies such as PRI, an excellent company, I might add, that you have to make sure that your coverage is appropriate, such that maybe you're returning as a part-time practitioner and you stop practice at a certain point with the COVID-19 pandemic as a full-time practitioner, or vice versa. You have to make sure that your coverage as far as full-time or part-time is the appropriate one. So if you're becoming part-time and you were paying full-time premiums, well, you're obviously paying way too much. And if you were full-time and now you're part-time, I'm sorry, the other way around. If you were part-time and now you're full-time, you have to make sure you're paying for full-time coverage, or your company could disclaim coverage, and you don't want to be paying that kind of money and find out that you're not appropriately covered. That's very, very important. Please, please, please check that out. All right. And lastly, if we could go to the, yes, thank you. This is common sense, But let's go through at least 4 scenarios, which I have seen in doctors' offices in the last week or two that on the best practices, they've done all 4 of these things. So you could phone call from your office that your office is reopened. You can send out postcards. That doesn't involve any kind of patient contact as far as touching. Now, also consider, and this is a good one, consider scheduling your patients so that the next patient could wait in their car. Or they could wait outside somewhere and simply have your front desk arrange to call their cell phone when it's their turn, such that there's a minimum amount of patients in your waiting room congregating in a closed environment. That minimizes interpatient exposure. It also minimizes the exposure between the patients and your staff. Your staff are going to see you doing this. They're going to love you for it. And your patients are going to love you for it too. It's fairly easy to do. It's not a big deal, but it can make a big deal difference as far as the psychology of your patients and your staff. Very, very good. So you also want to minimize the patient handling of papers and pens. So how do you do that? Well, perhaps on an initial office visit, instead of giving a pen and papers to the patient to fill out, you could have someone have it filled out, and they could dictate it to someone on your staff that's more than 6 feet away, or you could just hand them and let them keep the pen. If the pen is of a marketing nature, you could have your name and your address and phone number of your practice on the pen, let the patient keep it, and it's less back and forth between the patients and the staff. That's an important thing. Consider also having your staff sign in on the patient log instead of having the patient sign the patient log. Again, less interaction. If the patient's paying by a credit card, consider a no-sign option if it's at all possible, and that is possible for most credit cards these days, or the patient can give you express permission to sign the slip if need be, and that could work too. These are all common sense ways of having less back and forth with your patients and your staff. Now, again, let me emphasize that whether or not you decide to use a waiver, and that's a different discussion for another day. If you show your patients and if you show your staff that you are doing everything humanly possible to let them know that you are trying to practice in a best practices way, that will go a long way to keeping your patients happy as far as in regard to exposure to COVID, and as importantly, your staff. I can't emphasize that enough. Your staff has to believe, and the reality has to dictate, that you are doing the best you can. So there you go. At this stage, let me turn it back to our able Jesse Dresser, and we'll take it from there. Thank you very much for lending your ear for the last few minutes to me. I really appreciate it.
Thanks, Larry. So with that, we'll shift over to my colleague, John Morrone, who will give us a little bit about some of the opportunities that have been presented by this and what some of the practices might be able to take advantage of.
Thank you, Jesse. So one of the things that has emerged from the COVID-19 pandemic is the dramatically increased use of telemedicine. Now, for many years, we at Frier Levitt have worked with telemedicine providers and clinicians that were trying to enter into the telemedicine space and utilize telemedicine as an enhancement. Very often, those efforts were stymied by some of the existing rules on both physician-patient encounter requirements by boards of medical examiners and by payers. The two most common areas of obstacles was one is where the patient was physically located during a telemedicine encounter, and the other being where and when providers or payers would pay for telemedicine. So one of the many things that have occurred from COVID-19 is that both physicians and patients have kind of been forced into the telemedicine space, and both have become more comfortable with this remote technique of providing patient care. And some of the benefits of telemedicine for both provider and patient is that it allows for the accommodation of more patients, social distancing. The virtual encounters do not require a patient to travel to the provider's office. So imagine even in the context of the frequency of patient encounters, it doesn't need to be an all or nothing situation, meaning you don't have to rely totally on telemedicine, but initial encounters can occur in the traditional office environment, followed by telemedicine encounters periodically throughout the plan of care. It is also beneficial for the provider as they can retain patients who would very frequently seek care at an urgent care center or a hospital because the particular event is occurring outside of normal office hours. So if you can just imagine for a second, as basically every physician has experienced being on call and patients having to call a phone number, get an operator or a service, and then having the physician contacted and having to call back. Telemedicine allows for direct face-to-face encounter or direct encounter via technology, which most importantly, aside from being able to communicate more effectively with the patient and to visualize, or for the clinician to visualize certain parameters such as skin color, rashes, wounds, things along those lines. It is also a reimbursable encounter for the provider as opposed to just a telephone conversation. Specialists in particular can increase their patient base by reaching out and taking down geographic barriers to have patients interact with them. Also, in rural and medically underserved areas, telemedicine provides access to specialists that may be at academic medical centers hundreds of miles away, or just, we have a number of clients who have particularized skills in their discipline that attract patients from all over the country. And now those patients, rather than having to travel to a provider's office, can receive that care via telehealth. Another component of this is that it can now, in this post-COVID-19 environment, reduce costs by having less patients having to come to the office, less physical facility necessary, decreased real estate costs, things along those lines. And the other, and perhaps the most important part of telemedicine is, as I see it, is that it allows for an unparalleled continuity of patient care, maintaining that connection between the provider and the patient. That's not necessitate a trip to the physician's office. And this concept has even been enhanced and supported by CMS and many of the Medicare programs, such as chronic care management and remote patient monitoring, where patient compliance with things like drug regimen, diet, exercise, things along those lines can be monitored and tracked on a regular basis. And an additional concept behind this is that by allowing greater access and having the physician or other professionals being able to access the patient and having that patient being able to communicate, problems can be recognized before they exacerbate to the point of requiring an emergency room visit. So one of the most common causes of readmission is something like congestive heart failure. So by using remote monitoring or telehealth, a clinician can recognize that either a patient is retaining fluid or gaining weight prior to that patient becoming so exacerbated that they have to travel to the emergency room because they are in extremis from an inability to breathe. So telemedicine in the post-pandemic world really provides a wonderful tool for the clinician. Additionally, we have, as Jesse had mentioned earlier, several months now from executive orders that precluded patients from seeking care, precluded patients from having quote unquote elective procedures, which I would say that many of you would probably agree that there are many patients that should have sought care that didn't, particularly preventive measures such as colonoscopies, mammographies, things along those lines. So telemedicine allows for greater access, and there will be undoubtedly patients that even post-pandemic will fear traveling to healthcare facilities for fear of catching a virus or some other disease. Next slide, please. So some of the regulatory concerns with related to COVID-19 and telemedicine is that, as I mentioned, there were a number of barriers that created obstacles to telemedicine, and the two most common ones were where the originating site was and where their and reimbursement. We have a number of COVID-19 related waivers that have been put in place by CMS, by other payers, and by regulatory agencies. As Larry had alluded to earlier, documentation is critically important. So patients that you're seeing during the pandemic via telemedicine, if the waivers are applicable, please document in your chart that you waived the copay for a patient because it was during COVID-19, and Aetna had a policy of waiving that. If it's a Medicare beneficiary and the encounter is at the patient's home, you document that the originating site was the patient's home during the pandemic. We're uncertain as to what waivers will be made permanent and which will be reversed. Another key one for those of you that are out there that are pain management physicians, the DEA waived the prohibition on prescribing Schedule IIs via telemedicine. So again, make sure your chart reflects that when you ordered via a telemedicine encounter, that it was done during COVID-19. Just to move this along very quickly, I'm just going to touch on some of these other parts. Big question that always comes up is about licensing. That has not changed. There is some movement to allow greater cross-border provision of care, but generally you need to be licensed in the jurisdiction where you're seeing the patient. Contact requirements, as I mentioned, site of care, where the patient, originating site. Medicare has a variety of different types of originating sites, critical access, hospitals, rural health clinics, things like that. But basically, during the term of the pandemic, during the emergency, the waiver that's in place is fundamentally patient location is basically anywhere: patient's home, nursing home, other practitioner's office. Next, there's another waiver during the pandemic is the use of technology. Is that the waiver now allows for just commercial audio video connections like Zoom and things along those lines. Prior to the pandemic and likely post-pandemic, we'll go back to being secure platforms that are HIPAA compliant and that use some form of encryption. Physician-patient relationship or practitioner-patient relationship, your particular jurisdiction will determine whether a initial physician-patient relationship can be established via telemedicine. And one area where there's a lot of bad information out there and bad advice being given to people and practitioners. The use of telemedicine does not compromise the requirements to meet the standard of care. I admonish my clients that if you need to lay hands on a patient to make the diagnosis, to appropriately manage that patient, if you need vital signs and you're not doing remote patient monitoring, that you should not be making that diagnosis or ordering that medication via telemedicine. And then finally, be aware of how the particular insurer is allowing you to bill. Some insurers will allow or accept regular, the 99213, 9921412 codes, as long as the service that's being provided is consistent with the parameters for a traditional E&M code. Other providers, including Medicare, have specific CPT codes and modifiers for telehealth. Next slide, please. Okay, and in the next minute, because I'm running out of time, is for all of our providers out there, as you're returning to your offices, returning to some place of normalcy, you need to keep an eye on a number of things. If you receive the Medicare accelerated payments, understand that Medicare will begin recovering that money very shortly from future claims submitted. The COVID-19 related copay waivers, again, make sure that you're documenting that, and that and keeping track of those waivers, and if they expire, that you begin to collect copay. As I mentioned with telemedicine, make sure that you're coding correctly. As always, we can never ever reinforce enough. Documentation is key in your medical record, in your EHR. Now, the last two bullet points here, and something I just want to spend 2 minutes on, is that we at Frier Levitt handle a lot of government investigations, OIG, self-disclosures, as well as DOJ investigations. And we basically are on the phone or in communications daily with federal government and other enforcement bodies. Most traditional fraud investigations, including Medicare fraud investigations, have been slow rolled by the federal government because they've turned their attention primarily, and we've been told this by FBI, Secret Service, and DOJ, their attention is now on COVID-19 related frauds, price gouging, N95 mask frauds, and a variety of other claims by everyone from manufacturers of holistic medications to traditional medications, claiming to cure COVID-19, prevent COVID-19. And so some of those investigations pre-COVID-19 have been slow rolled, and we're going to see them being re-implemented towards the end of the year. But you may also want to be advised that there are a lot of COVID-19 related enforcement actions going on right now. And so you want to be very careful. There will be complaints being made. And that's one of the reasons we're having this webinar, so that you can get back to the practice of medicine in a compliant manner, in a manner that serves your patients and keeps you, your staff, and your patients safe. Thank you. And with that, I will turn it over to Chris.
Thank you, John. It's very insightful information so far with respect to some of the emergent issues affecting providers in the COVID-19 world. To that end, I'd like to discuss a little bit about the Federal PrEP Act and provide just a brief background and then move on, because I find that having at least some sort of a background as to why a particular law was written is always helpful to interpreting what it means. So with that said, I'll begin with the PrEP Act, which stands for the Public Readiness and Emergency Preparedness Act. It was passed by Congress and signed into law in 2005. In passing this law, Congress acknowledged that the potential for lawsuits in part against frontline medical professionals existed, and then that posed a threat that could act as a significant deterrent to those people who we so desperately need to treat the sickness or disease, as well as developing vaccines and treatments for pandemics, much in the way that we see here with COVID-19. So in recognizing the need for the quick response to public health emergencies and protections for those who respond, that's Congress passed the PrEP Act. Now, with respect to public health emergencies, those are declared pretty frequently, and some of the better known public health emergencies that have been declared recently have been with respect to the H1N1 flu and Zika virus, but the government can also declare public health emergencies with respect to natural disasters as well, though they don't always invoke the PrEP Act. And so on the next slide, what we'll do is we'll talk about how the PrEP Act is invoked. So the PrEP Act isn't a law that's constantly in effect. It, like I said, must be invoked by the Secretary of Health and Human Services in response to a declared public health emergency. In this instance here, the federal government declared a public health emergency with respect to the 2019 coronavirus on January 31st, and they made that declaration effective retroactively to January 27th, I apologize. Public health emergencies are good for 90 days, and they can be renewed every 90 days, so long as the emergency exists. Now, once a public health emergency is declared, and the Secretary of Health and Human Services must make an official declaration, then invoking the PrEP Act to provide immunity with respect to that particular public health emergency. So there have been numerous public health emergencies, as I've mentioned before, but not every public health emergency results in a PrEP Act declaration. As the example that I used before, with regards to the public health emergencies, there are also PrEP Act declarations issued for the H1N1 flu and Zika virus. So in response to the overwhelming need for treatment of COVID-19, the Secretary issued a declaration invoking the PrEP Act on March 10th, 2020. And they made this immunity that applies via the PrEP Act apply retroactively to February 4th, 2020. So a little bit about this. The declaration grants broad immunity for all claims of loss against any covered person with respect to the use or administration of a covered countermeasure used to treat, diagnose, or mitigate COVID-19. I do want to note that immunity is not perpetual. It only lasts through the final day of the public health emergency, or within the declaration has listed an end date of October 1st, 2024, and that's whichever comes first. So it's in effect for approximately 4 years or until the public health emergency is declared over. With respect to the PrEP Act immunity, I've enclosed excerpted the actual text of the PrEP Act. Simply stated, the PrEP Act provides broad immunity for covered persons for any claim of loss with respect to the use of covered countermeasures. Now, notably, the loss must be caused by use of a covered countermeasure for immunity to apply, and those are defined terms that I will talk about a little later on. So with respect to claims of loss, the type of loss that is covered, that's covered by immunity here, includes death, physical, mental, or emotional injury, illness, disability, or condition. It also includes fear of physical, mental, or emotional injury, illness, disability, or condition. It also includes damage to property, such as business interruption loss. So, for example, if a business owner is somehow injured because of a covered countermeasure during treatment, he or she will not be able to sue for lost wages as a result. That would be a claim that would be immune under the PrEP Act. Notably, there are some exceptions here, and I'll go into a little more in depth, but just to kind of advise of those. The PrEP Act does not provide immunity against civil, criminal, or administrative actions brought by the federal government. And so that's something to be aware of. And that brings us to our next question of what is a covered countermeasure? The PrEP Act broadly defines a covered countermeasure as any product that's used to treat, diagnose, cure, prevent, or mitigate COVID-19 or the transmission of SARS-CoV-2 or a virus that mutates therefrom. So essentially what it's done is it's created and carved out its own definition here and says that if this disease were to mutate, it does not require a subsequent declaration. It's still covered under this declaration. And so it also includes any device used in the administration of any product and all components and materials of that product. One of the other requirements is that this product must be used for COVID-19 in the treatment and approved, cleared, or licensed by the FDA. So any product that effectively satisfies those criteria is considered a covered countermeasure, notably, and it includes this expressly in the language. That does include potential vaccines as well. I know we're still a little bit ways away from vaccines with respect to COVID-19, but the PrEP Act was drafted and is meant to include vaccines as well. Also, covered countermeasure is any product described in these emergency use authorizations. Now, you might have heard that recently hydroxychloroquine was removed from emergency use authorization lists. And so they do actively review these EUAs and they add and remove these items as necessary. Recently, there have been positive results with dexamethasone, excuse me, that's a tough one, dexamethasone, I apologize. Though it is unknown whether that product will be given subsequent emergency use authorizations. There's also numerous other categories that have received emergency use authorizations under the PrEP Act, including N95 respirators, face shields, and other types of PPE that have been authorized as covered countermeasures. So these emergency use authorizations are not solely limited to medicine. It includes devices, diagnostic tests, and even ventilators. So you really sort of get the idea that the Act starts to paint with a broad stroke, and the covered countermeasures are definitely too numerous to list all of them. However, the federal government has provided a list that's available at the FDA website. But I would caution that those lists are not exhaustive. They certainly don't contain every covered countermeasure. And so if you're looking for a covered countermeasure, it might not appear on that list by name, but it may still be covered. Which brings us to our next question about who is covered by this act and who is a covered person. So covered person, much like covered countermeasures, is very broadly defined by definition. And so with respect to the administration of a covered countermeasure, a covered person includes the United States, but it also includes any person or entity that is a manufacturer, distributor, program planner of such countermeasure. It also includes qualified persons who prescribed, administered, or dispensed the countermeasures, or any official agent, employee, or person of the entities mentioned above. So how might this apply with respect to protections for providers, right? What is particularly relevant here? Can we please go to the next slide? Thank you. What is particularly relevant here is that the definition of a qualified person, it means a licensed health professional or other individual who is authorized to prescribe, administer, or dispense countermeasures under state law. Now, the secretary may even designate additional persons qualified within that definition, and has in fact done so already by naming licensed pharmacists to be able to order and administer FDA-approved COVID-19 diagnostic testing. As a result, the definition of covered person broadly includes practices like hospitals, doctors' offices, and emergency care centers, but it also includes their individual doctors, pharmacists, physicians, physician assistants, nurses, and even their employees with respect to any claim of loss that might arise from their administration of a product or for treatment relating to COVID-19. So Congress really intended to protect our first line responders and those people who take part in this crucial fight against COVID-19 in any practically any way that they can. And so this immunity is particularly relevant here with respect to providers when you see it covering PPE, diagnostic testing, and even covering these vaccines that have yet to be developed, but will no doubt be so crucial in the fight against COVID-19. So it's also worth noting that because the PrEP Act is a federal law, it preempts or supersedes state law that is in conflict with it. So as an example, one that we actually discussed earlier, the Secretary of Health and Human Services has designated licensed pharmacists as qualified persons under the Act who can order and administer testing. So some states, however, prohibit licensed pharmacists from ordering and administering test supplies. So you might have a question about, well, do I follow state law or federal law? And actually, the federal government has issued advisory opinions effectively overruling and preempting state law. And it permits licensed pharmacists to order and administer diagnostic testing. With respect to that, I do want to talk a little bit about reasonable precautions here. And even though that the PrEP Act does provide broad immunity, a covered person can still be sued if his or her actions amount to willful misconduct that approximately causes death or serious injury. So providers should still take reasonable precautions in maintaining the standard of care. Likewise, the PrEP Act would also not prevent someone from filing suit in court and attempting to challenge this immunity. So in order to best protect against these claims, it is good practice to document any reasonable precautions taken with respect to the purchase or use of covered countermeasures so that you can effectively defend against potential claims in that respect. There's also certain exceptions that permit immunity to of that sort that would kind of tie into the reasonable precautions. For example, there's a reasonable belief safeguard in the PrEP Act where a person or entity that otherwise meets the requirements for PrEP Act immunity will not lose that immunity, even if the product is not a covered countermeasure, so long as the person or entity reasonably could have believed that the product was a covered countermeasure. So to kind of break that down and wrap our heads around it, example, if you're purchasing PPE or COVID-19 diagnostic tests from a reputable regular supplier and you take steps to authenticate those products, but some or all of them wind up being counterfeit, immunity would apply to any claim of loss, even though the counterfeit products are not covered countermeasures. So again, this keeps in line with the broad immunity that the Act issues, as well as the purpose behind the Act to allow for a rapid response against COVID-19. One last thing, the federal government has also stressed that all covered persons using or administering covered countermeasures to document reasonable precautions that they have taken. And this is to ensure the safe use of the covered countermeasure, but is also to help protect against these suits and help to assert immunity. Immunity coverage is determined on a case-by-case basis, and so the number of products here, as I've stated before, is too numerous to list. So I would encourage you to reach out if you have any questions regarding whether you or your practice are covered under the PrEP Act, because the federal government has made it mandatory for people who are seeking immunity to determine whether or not that immunity applies to them. And so with that said, what I'll do is I'll turn it back over to Mr. Dresser, and he can go from there. Thank you.
Great. And so it seems like we only had one substantive question, and that was about the business safety plan. So I want to just pull up real fast what the New York Business Safety Plan looks like. It is a document that's fillable, requires you to sign off on certain things and identify how you're going to think critically about how you're going to avoid and deal with certain things that, for example, you can't adhere to 6 feet of space, something like that. Also discusses things like protective equipment, so on and so forth. And so we've worked with folks in completing these. And then at the end of it, you have some space to include anything else. We've been appending, in some instances, policies and procedures. This has to be maintained in the event that it has to be posted and maintained in the event that you are visited by a particular Department of Health or other enforcement agency. I see one other question. If an employee calls out with symptoms of COVID, we are requested to get tested, since then has not communicated with the company, is unable to be reached. What steps can be taken? So if they've tested if they've been tested and they haven't indicated whether they are positive or not, it creates kind of a tricky situation, because if they are positive, you can direct that they stay home. If they are not positive and they no longer have symptoms and they've gone through the isolation period, and it's merely an issue of them being afraid of coming back to the office because of COVID fears, that's where you start to get into the realm of being able to consider taking action against them. But at the end of the day, there are so many moving parts and so many different factors that it's really important to kind of analyze each by itself. So I would encourage anyone that has any additional questions, feel free to reach out to us. We have our contact information here, and I hope to speak with many of you soon.